Everyone. How's everyone doing? So it's a new day, another series, another work day. I don't know if you are working today or if you are just sitting at home chilling with a cup of coffee. So I welcome you all to another series of Rodinar, which is one of the first things that we are doing in dermatology. This is a fun concept where the doctors are going to be on the road discussing their busy life, busy schedule, their patients and their passion, which is dermatology. So what we plan to do in today's segment is probably discuss one of the most important topics that we deal with on a day-to-day basis, which is atopic dermatitis. In this fun concept where we go around the city, show you the city, give you the briefs of the city as well as the disease. Come, let's go ahead. Again, as I wait for all of my friends to arrive and colleagues to arrive for the day to begin, let me introduce myself. I'm Dr. Sameepa Mukherjee. I'm a practicing dermatologist and I specialize in pediatric dermatology. My areas of interest include clinical dermatology, trichology, atopic dermatitis and everything related to pediatric dermatology. I'm here in Bangalore since the last almost 8 years and currently I'm a consultant with Cloud9 Hospitals as well as I practice at my own clinic, Dr. Sameepa's the Skin, Hair and Nail Clinic in Hennur in Bangalore. So let's go ahead and wait for my friends to join in and let's start the day. So I'm going to be very partial and biased right now because I am into pediatric dermatology and I'm going to be dealing with more of eczemas and specifically so I had a few doubts in my mind, so I just wanted to clarify them. So are you seeing a lot of atopic dermatitis patients post-COVID? Are you seeing that happen?
Yeah, post-COVID, now we are noticing that patients are coming with eczemas, dermatitis,
even urticaria.
Urticarial rashes, yes. I think even I am seeing that very often and like sir rightly pointed out that we are seeing a lot of flare-ups and atypical flare-ups like, you know, the child may not really have a bout of fever. Patients have, the family is positive for COVID, but the child comes with a flare-up of exacerbation. I remember like, you know, patients always asking that is it the genetics which, you know, actually aggravates atopic dermatitis or causes it? So when they ask that, how do you really tackle that question?
sometimes we take the family history, whether they have any symptoms of atopy, like asthma, sometimes they have rhinitis and also eczema. Definitely there is a big role of genetic plays in atopic dermatitis.
So what was the most complicated or the difficult case that you came across? Like, do you have, I'm
Yes.
sure in your huge practice of so many years of experience.
I have really some of the atopic dermatitis. One small boy, I had a long-term follow-up, and not just I. Whenever I meet him, he was admitted in St. John's. Me and my colleague Dr. Elizabeth was treating. Almost now he has become a software engineer. He still comes to me. His atopy is still there, but he always believes that he has stopped the steroid creams, everything. He went for an alternative medicine. I don't go deal with the thing. But generally, it continues for a long time. In fact, he was quite disabled when he was thing, and later on he became a software engineer, and that is a one difficult case which I tried everything. Uh, I failed in the thing. Sometimes some cases do not respond. Maybe biologics and other thing were not there. Now it is there. Now one more patient recently I have. Now she is coming to me. She came all the way from Maldives. In fact, she was treated in Kerala with cyclosporin. And in fact, when I see her, uh, generally the parents are hairy because father came, can I do hair removal? He asked in my clinic. But the patient, because of the steroid, internal steroid and application, lot of hypertrichosis, then vascularity is there, and she has taken little bit of Cushingout features she has got. She is using topical steroid. She doesn't want to use steroid. Now we are thinking, in fact, I will take an opinion other than this, you know, uh, what to do with the child, what to do with this girl who's 20 years old. They are given cyclosporin for 1 year. After cyclosporin, it is stopped. She got scared because she should get the BP done, then her electrolyte to be checked. In a country like that, it is difficult. Then they gave up. Now they are ready to go for biologics. No, such difficult cases I have faced. Now we should think about what to do. In fact, I am taking opinion since I met you. I'll also take your opinion, so how to manage. One other child, in fact, I uh, asked them to consult Dr. Mary from Mary Augustine in St. John's. She takes care of pediatric thing. They used to send a video from London that the child was so much itching they had. It used to they go roll on the ground and pour water and roll on. That was the situation. They flew back to Bangalore and she was managing. Maybe she would have given cyclosporin and other thing. In UK they don't give cyclosporin. Why? Because that stage, to get a doctor appointment, it takes a long time. First you should go to the thing. You go to another practitioner. They'll send you to a specialist. Then, like us, it is an advantage in India. We can straight away take the patient, investigate and give that. But not in other places. Yeah.
Right. I think accessibility plays a very vital
So those are some difficult cases, and some patients I put them on phototherapy because phototherapy maybe it will really beneficial, or it is more psychological. They come to the doctor, they go into the chamber, okay, and really it helps in evidence base also. There are some reports, some 30 to 40% of patient with the combination it helps.
What about you, Chakravarti sir? Do you have like any of these cases that has stuck onto your mind for a long time because of?
Not really any specific case thing. I do agree with sir. We have got lots of recalcitrant atopic dermatitis, but we face little bit of more of infectious disease in this kind of things, especially the impetigo or folliculitis. This happens very commonly. Then it makes us difficult to treat because we have to treat the infection first. Then we have to start on with the steroids or calcineurin inhibitors, whatever. So that inhibits our treatment, and especially the children with more of hand dermatitis or foot dermatitis. Again, that gives us a big headache. And juvenile plantar dermatosis.
Yes, I think
Again,
that's
that
one
is
aspect
also
which is very
very
understated, but it's there and it is
and
very
it always
prominent.
prominent.
I think for me, sir, I think I've seen a lot of these atopic erythrodermas because probably because I'm more into pediatric dermatology. That's why those cases have turned up. But there was this one case which I saw very recently, like just about 6 months back, completely atopic erythroderma, and the child was given oral steroids, Cushingoid, HPA suppression. I wanted to shift the child into cyclosporin. We tapered the steroid. We kept everything ready to start oral cyclosporin, and then the child had COVID. So the pediatricians were like, no, you can't give, you can't give, you can't give. So I think that was one problem that I faced in the recent times. And of course, like the repeated exacerbations, I think what is most important for us to do for these kids is the constant hand holding that they need, because this is something which is going to be there for a while. So it takes a toll psychologically, financially, and sometimes it is even mentally, because everything is exposed, everything is there out there in the open, and they are seeing it. And like you rightly said, sir, with the advent of COVID, we were seeing a lot of sanitizer users, so recalcitrant hand dermatitis in these kids. That became a very difficult situation to manage as such.
Because all the schools are emphasizing on
Yeah,
sanitizer,
yeah, yeah,
sanitizer,
exactly,
sanitizer. That's what it
exactly,
will be.
exactly. So, and cases of contact dermatitis started becoming more common, because they started using gloves and they were wearing the mask, so you were getting dermatitis around the face as well. And yeah, those were some of the.
Sameepa, I want to ask you one.
Yes.
Now, nowadays, these vaccines have started. Many of these children with atopic were going to school and colleges. What about this COVID vaccines for these children? What?
Okay, so what
So, in the guidelines, they say any other vaccines we can give when the active lesions are there to avoid the live vaccines.
Correct.
Okay, now they have passed through that stage.
Correct.
Now is they are in the COVID stage
Correct.
now. So how to manage this?
So again, for
children.
this, so
Now it has been protocol has
Yes.
been given.
oh, is it?
I mean generally no.
Huh.
Now they
Yeah.
about 12 or above 15 they are giving the COVID vaccine.
Yes, yes, they are receiving it, and actually, I do get a lot of queries on it. One thing that I tell them to make sure is the injection site should not have lesions. Second thing, I always tell them that if there is a flare up that is ongoing, avoid the vaccine during that time. Once the flare comes down, then you can go ahead and take the vaccine. And the third thing that I always tell them and counsel them is post the vaccination, after 3 weeks or so, you can expect a flare up happening, because you will have an inflammatory response. So these are the three things generally I tell them, and they've been doing pretty well. I have not really seen vaccine related complications or afflictions in these
I think
patients.
now since the vaccines have
Yeah.
started,
Yeah.
above 12 they are giving.
True.
Above
Yes.
they started now. Wait and watch what will be the
What will be the repercussions?
repercussion on especially
Absolutely.
atopic dermatitis. What should be
And
the-
do we need to stop topical steroids or
No,
something?
I don't
on
think
the-
so. I don't think so. I think ongoing medications can be very much there. Absolutely. I don't think you need to stop it, because like we always tell the
Definitely, we
parents
can
also.
go with cyclosporin.
Oh yes, absolutely.
we
You
can go with it.
You can.
Maybe
you can.
topicals we can.
So topical steroids, I don't stop it, because we are generally using mid or low potent. We are not using super potent steroids, and calcineurin inhibitors also will not really impact the vaccine. So yeah, so long as your vaccine site is clean, I think it's fine. It's a good to go. Yeah, so having gone through the complications and all of these complicated cases, I don't know. Sometimes I feel that maybe we should have something extra to offer to our patients, and how best can we holistically approach atopic dermatitis rather than just treating it as a disease per se, because for the patient I feel it is more of their life for those many years that we are actually handling, or we are telling them to handle better. So so with regards to treatment, when you go and explain to the patients, there will be so many thoughts about the treatment in the minds of the patient. If they are teenagers, if it is the parents most of the times who will be ruling the roost, because they will be telling you that, okay doc, you do this, don't do this, please give us this, please don't give us this. Do you face such situations where where your patients' parents probably dictate your treatment protocol in some way or the other, and how do you handle or go about tackling those situations?
especially in atopic dermatitis or any especially eczematized dermatosis, whatever the definition we take as, people, the parents nowadays, they are very much aware about the usage of steroid and other things. They tell us, doctor, please don't give any steroid to our child. Okay, so this is the first, before we think about prescribing, they tell us.
Yes.
Now we should take some defensive or method to tackle these patients, and I tell them what are the steroids, how long it has been used, what is the benefit of it. I also tell them, see, If you remember the famous, the President of United States, everywhere he was bombarding, telling after COVID I took steroid and I become completely better. So steroid has definitely got a role if it is being used properly in a right way and correct potency of the steroid. If it is a topical application, definitely it is justified to give steroids, because use of steroid, because steroid only has saved our many of our patients comfort and also the compliance also. So that is the important thing. How you use it, how what are the advices you are giving to the patient is important.
I think who gives the steroid, how they educate the patients about using the particular medication, it becomes extremely important. So do you also prescribe, like of course we say that moisturizers are the baseline therapy, so do you prescribe the moisturizers as a part of lifestyle change for these patients, because that is something which is used on a
Most of the
daily
time,
basis? So
on daily basis, a good moisturizer, um, good in the sense it should be having good the acceptability for the patient, easy to apply. The parents, the child, mother can also easily apply after a bath. We give all the thing, and good ceramide based moisturizers,
Fragrance free.
fragrance free, as he told. And I always give along with the thing, and we continue to use the moisturizer along with the topical corticosteroid of the. But what happens, the educated people follow.
correct.
People who are less educated, what they do is, suppose a doctor has prescribed some steroid to the patient, even a high potent steroid, they will try to use this. Oh, that problem is looks like something similar. Why to go to a doctor? Why to go to a pediatric dermatologist? Why to go to a dermatologist? Let us use this.
And see if
There
it's
only
working or
the
not.
misuse has
Problem
become more.
starts.
When the misuse starts there, they automatically buy the very potent steroid.
Right. So that's one thing, like, pure prescription should not happen. It should not like go on from one person to the another. Like, yeah, that's very common, and we see it very frequently happening.
Many people come and ask you, can we use coconut oil as a moisturizer?
Yes.
What in the
Yeah,
period?
so I think coconut oil is one of the best moisturizers to be used, because freely accessible down south in India. And second thing about coconut oil, especially the virgin coconut oil, is the percentage of oleic acid is the lowest. So it has the least irritant potential. And secondly, the density of your coconut oil is almost similar to that of the natural lipids on the skin. So yes, we do recommend the usage. So that is one thing which we stick by, that's one thing we allow them to do. It's not that all the myths are bad, but yeah, oiling is something which we allow to do. But I think for your place, humid areas, it may be difficult, isn't it?
It gives little bit of occlusion, and sometimes it goes for infection, ma'am.
Correct.
And it's also a bit of rich culture media too. So especially the place where we live, we get lots of infections. Especially
Like secondary
atopic dermatitis,
occlusional folliculitis and things like that.
we experience. So I
Yeah,
usually
so humid
say,
areas, maybe we
not
should
to
be
do
a
that
bit
one, go
careful
with
about it.
moisturizer. That's what we advise.
Yeah.
And we advise non-soap cleansers. That's more
I
important.
was just coming to, from the foam, I just remembered, should we use foaming products for these kids, or should we just stick to the non-foaming cleansers?
Non-foaming cleansers is what is my choice.
So
but I
what
don't
about
know.
you, sir?
Yeah, I give, but we always go on the pH balance now. Everything is pH balance.
Yes.
Even in
Yes.
atopic dermatitis,
Yes.
they say the pH change only is the barrier function is lost
Correct.
because of that.
Correct.
So that
We
pH
have to be
balance.
mindful about it.
Yes.
And all thanks to social media, pH, parabens, they have become a rage. So we
Sulfates.
yes, sulfates, they are all wanting it to not be there or be in the right
products.
proportions in the products. So yes, so do you ever feel that in the topical therapies, maybe there is somewhere a gap, something which can be put in, some additional thing can come in, and if it does, it is going to help us a lot? Do you think that way? I mean, amidst your moisturizers, amidst the topical corticosteroids and the calcineurin inhibitors that we already have, and now of course another rage is topical probiotics. So do you really think that there is a gap that really requires to be filled?
Definitely, there's a gap, because when you look at it, moisturizer came in, steroid came in, calcineurin inhibitors came in. Now we should think about something which will really be helpful, which is steroid free. Many
Correct.
people ask this question,
Yes.
don't give us steroid.
Yes.
Now what is the option?
True.
So we should think about it now,
Yeah.
right from the very beginning.
Like, I think research science is always an ever evolving field. What concepts we had 10 years back is not holding true anymore.
No.
We are changing it ever so frequently. So I think, yes, so all of us agree on the fact that we do have scope for a new molecule to come in, isn't it?
Definitely, ma'am. We have, because it's a complex thing, atopic dermatitis is like lots of things involved, like epidermal barrier function should be restored. We have to inflammatory mediators should be suppressed. Its cycle should be pathway, TH pathway should be maintained. All these things. So we have to look into all the things. And if you take one molecule, it will be doing one work. It will not be going with all this. So we need some more newer inventions for this one.
Right. So, yeah, I mean, I think atopic dermatitis is one of the most complex diseases to treat, is what I personally feel, because molecular pathway, if you see, you can block so many levels, and you can probably get a drug out for each of these levels so that it performs better and better, right? So what is your take on crisaborole, because that's the next big thing that's coming up. It's something which patients are already using in the US, and we do have a lot of inquiries for that particular molecule, especially from patients whose relatives are in the US. So
Crisaborole is a molecule which acts on a immunological thing, something like what apremilast, what does it systemically, it does topically.
correct,
Very simple.
right,
We have been using apremilast for psoriasis and atopic dermatitis, mostly in psoriasis. Same thing is going to come as a topical.
correct,
Very simple. Okay, so it is much more easier to use it. So we should wait and watch. Many reports what is coming for crisaborole is use it at an early age, like as you are a pediatric dermatologist, you can use it at the very start. They say right from 3 months since you
onwards.
can use.
Yes.
That
Which
is
is
a
not
safe-
there for, I
Yeah.
think that is not there for even
Tacro-
topical calcineurin
yeah,
inhibitors, isn't it?
Yeah.
So that's a big boon. There is a gap, there is a need for that 2 months to 2 years wala period where, we are short of molecules, because you don't want to give steroids for a very long time, and you want to use something else, but you don't have approvals for anything else. And if crisaborole comes in where it is approved, there is a very, very good safety profile to this particular drug, and I think the only contraindication is contact sensitization or allergy to that particular molecule. Otherwise, it doesn't come with a black box warning. It doesn't come with any of the warnings as such, or contraindications to use it. So maybe we should be
that's
able
a very interesting molecule. When we go through the literature, see, it is US FDA approved, European Council has approved the drug, Canadians have approved, in Israel it is approved, Australian approval is there. A lot of approval is coming, but it can be used as they say, is a rescue therapy. What they say is, when people don't want to use steroid, they say, I don't want to use steroid. What is the rescue there? That is the time we can think about using.
Yeah, so basically those steroid phobic
Yes.
patients where they don't want to use steroidal medications. Yeah, so sir, do you think we should be able to place this particular molecule in our practice as a first line therapy as well in certain conditions and in certain
Definitely,
cases?
in your case, as a pediatric dermatologist, in a very early age, if you think about atopic dermatitis, you diagnose in 3 months and 4 months. What is the remedy? All we are practicing is to use the topical steroid. As Chakravarti told, you cannot use calcineurin inhibitor, above 1 year only we can use. There are a lot of restrictions. At that time, instead of steroid, we can use this.
Yeah. So
This
does this
very
become
early
like a
age.
first line therapy as well? Like
In a
even
very
with
early
steroids sparing each
yeah, in a very early age group, we should do some trials to start this drug at the very thing, how they are going to respond, how these children are going to, except as you told, in 4 to 10% of the people, they complain of pain, irritation, sometimes they get even some respiratory infection, they say, upper respiratory infection after topical use. There are some reports on that. So other than that, if there are no irritation, safely we can use. We should now, once the drug is launched, we will get an answer for this.
Yeah.
If you ask me personal experience, I don't have personal.
Okay. Yeah, I think personal experience, none of us have it because the molecule
So
is not available yet. But once it becomes, I think all of us are going to be very excited to use it and see how it really does on the field, because sometimes the theoretical data does not really match the practical data. So we need to see where we can position this particular thing. So I'm going to actually ask you, because I want to reduce my work. So any insights you can give us on the trials that have been done on crisaborole so far? Either of you, sir? Like, that's from our knowledge, because I don't want to read the papers. I want to enjoy the weather, and I want to hear from both of you.
No, really, this drug with a lot of trials, which they say, it is in some trials they say with randomized controlled trials, they say this drug is good, maybe up to 40 to 50% clearance is there in the patients, except occasionally you just discuss, it can produce little irritation, that you should watch. Even when you used calcineurin inhibitor earlier, we had the same problem. The irritation was a component. Okay, many people complained of little bit of irritation, and sometimes they say little pain also been associated at the site where you apply, especially in the flexural area. But one review which very clearly says calcineurin inhibitor can produce irritation more, steroid cannot be used in the certain area like intertriginous area, flexural area, but this drug is quite safe to use in the flexural areas and other areas.
Oh wow! So that means to summarize my understanding, it is basically a steroid sparing agent. It will do the work of a steroid without causing the side effects of a steroid. So we can safely go ahead and use it. And secondly, the irritation potential being lower to that of calcineurin inhibitors. We do not have to tell them to keep it in the refrigerator, etc., or cool it down before using it, or use a moisturizer before you apply this particular product. So I think it will make life very simple for the patient's parents, because they have to do less work then.
That's the right thing, ma'am. But we have to wait whether we
Yeah, we
can
have to.
substitute for the moisturizer. I don't know.
No, not
You
a
cannot
substitute.
substitute
It's
for
not a
this.
substitute. So
Moisturizer will stay
moisturizers
on
will
till
be there,
as long as
yes.
atopic dermatitis
That is
is
there.
Yes, absolutely. It cannot be a substitute for sure. So only thing is, I generally tell my patients who complain of irritation due to calcineurin inhibitors to use a moisturizer first, followed by the calcineurin inhibitor, and after cooling it. So that reduces, that numbs off the TRPV pathway which it stimulates, and thereby doesn't give irritation. So I think if this drug will not stimulate that pathway, then we will not have that problem. They can directly apply it on the lesional skin. So do you think, sir, this can also, like how we use proactive therapy for topical calcineurin inhibitors, even this can find a place in that?
Maybe.
Yes, maybe? Yeah, okay. Yeah, we have to wait and watch. I think we are all waiting in anticipation for this particular molecule to really come in. The other thing I was actually concerned about was the body surface area. Do you think with its excellent safety profile, we'll have a restriction on the usage of how much we can use?
See, they say 40% and less body surface area in atopic dermatitis, you can use this drug.
Wow.
Above 40% we can't.
But 40% is huge, so when
Yes.
we're thinking of the infantile age.
See, usually flexural dermatosis and all, we usually look into 10 to 20%.
Yeah.
Okay. But when you take above 40%, you should think about other systemic
Correct.
drugs like cyclosporin or other drugs. Okay. So there is a role, because when you look into atopic dermatitis per se, less than 20% will be more than 50% of atopic dermatitis, like flexural areas only. Mild dermatitis only will be around 30 to 40%. Only that group which is above 40% will be only 5 to 10%. Max.
Maximum. True.
So we should think about less than 40% is the approval. Systemic absorption, it passes through the urine very fast, 11 to 12 hours of the exchange thing. So no accumulation of this drug in the thing. Like steroid, when you use it, it can suppress the HP axis even topical. That problem is not there because it is excreted in the urine much rapidly.
Yeah. And my thoughts are right now running at lightning speed. I am already contemplating the use of crisaborole not just in atopic dermatitis but in disorders which have overlapping molecular pathways. So
Yes.
yeah, I'm thinking of
Yeah, maybe one.
Maybe?
Maybe some studies are coming
Yeah.
in seborrheic dermatitis is very useful
exactly.
because where we are using pramicolumis or tacrolimus in seborrheic dermatitis. Now in seborrheic dermatitis there is off-label indication of crisaborole where it can be used.
Yeah, so I think once this drug comes in, it's going to open up Pandora's box of indications to be used for. Of course, we'll have to be very diligent about it because we cannot randomly use it for all the conditions. But like Sir said, seborrheic dermatitis, overlapping pathways, maybe psoriasis, I don't know, early stages,
Yeah,
initial
totally.
stages, we don't know, maybe. Alopecia areata, again, I'm thinking too fast, too far ahead of time. But maybe these will down the line become offline indications because if you go by the molecular pathway, all of these conditions have certain overlaps with your atopic dermatitis inflammatory pathway.
As we are discussing about this, one thing about this allergen set in the molecular weight of this product is much more lower than compared to other products which is topically used. Like you take calcineurin inhibitor, so many Dalton, okay, it is about 800 Dalton, whereas this one is only around 217 or 215, okay, Dalton. So it can easily penetrate through the skin level. It can easily penetrate to the subcutaneous area. So that's the reason this drug has got a promising this one at a thing because the penetration is much more easier.
True, so maybe the time required for response also is going to be lesser as compared to calcineurin inhibitors.
Yes,
And
because
the
you can put
duration
it
of
as a
treatment can
piggyback.
come down.
You put on the good moisturizer where the barrier function can be restored, and you can put this along with the thing so that easily it can go
Wow,
inside.
amazing. This
Yeah,
is what happens
is what-
when research and practical knowledge conglomerate. And even if we are out on a setting where we are sitting in a beautiful garden in Bangalore, we are still thinking science in every single thing. Sir is talking about allergens because that is what I picked up from the environment, right? And Sir is talking about the kilodaltons and the daltons, and he's combining the science with environment.
We should wait and do it, and we should be little patient. See, for example, calcineurin inhibitor initially when it was launched, many people were never used.
Yeah.
They use the off-label indication for vitiligo and other things. Still we use it. Still use it. Yeah. Yeah. So it is a half-label thing. But the real label indication is atopic dermatitis when the drug came in. It was very lately it is picking up and coming. So now with the new molecule, we'll wait and watch and we'll try.
I think that's very important for every new drug that comes in. Constructive criticism is something which is going to be beneficial for the drug as well as for ourselves. We should not really be, we should be absolutely positive about the drug because it's a good thing. Any new thing that happens is good. It is probably going to take some time to establish itself, and we will probably need some time to actually position the particular drug in our practice, and waiting in anticipation for the drug. And ultimately, it's for the greater good, isn't it, sir?
Yes.
Patients are our focus point. And I think when we have a fresh thought, we have a fresh mind, and we are relaxed, we all deliver our best, right? So yeah, so 3 cheers for Rodinar series and 3 cheers for crisaborole. We are waiting in anticipation. So hip hip, hooray! Hip hip, hooray!